Agora são exatamente aí às 7h10. Estamos online e dando sequência para a apresentação do Rob Peters. É isso? Muito bom. Robert, me escuta? Hey, hi Rob. Hey, good to have you here with us. Thank you.
My pleasure to be here. Thanks so much for the invitation.
Okay, so good. You're good to go. The floor is yours. Thank you.
Excellent. Well, I'll start sharing my screen and just want to again thank you for the opportunity to present to you all on the quantifiable clinical benefits of AIR Recon DL. And I assume you can all see my screen and you can hear me okay. So let's get into it. So yesterday, I believe you heard my colleague Yuko talk about and introduce to you AIR Recon DL as a means of, it's a deep learning based tool that is a new novel reconstruction that provides a number of different clinical benefits. And you saw probably a slide that looks something like this with some bullet points and some nice messages. But today we're going to talk a bit more detailed. Let's dig into some of the more detailed observations, the clinical benefits of AIR Recon DL. And I'll preface this by telling you that it all really revolves around how we balance resolution, scan time, and the image SNR. What you're going to see is AIR Recon DL can manage these three quantities simultaneously, unlike conventional reconstruction wasn't able to do. In the past, if you wanted one of these three things, it came at the expense of the other two. And so we will see shortly how AIR Recon DL can give you all of those things together. And let's keep in mind, really, the two main things that AIR Recon DL provides is it delivers images that are sharper and appear with higher resolution, and then it also gives higher SNR, signal to noise ratio, with a user selectable level. It is an algorithm that sits between the raw data and the final image. So let's keep those two things in mind. This is an algorithm that does two things, two separate things, but of course these are all combined in the final offering, sharpening images and delivering higher SNR. So we're going to go through today quantifiable clinical benefits, talking about the improvement in the resolution, the increased signal to noise ratio, expanding the clinical usable protocol space. I'll tell you what that's all about, how it can deliver consistent scan times, and of course, shorter scan and exam times, higher diffusion B values. We'll see how when it gets applied to diffusion weighted imaging, it can deliver higher diffusion B values. And then lastly, as we close, let's talk about some things that we would also like to quantify, but maybe at this point, we're not quite at that point where we can. Namely, images that are easier and faster to read and eye fatigue. So that would be something that we would really like to learn more about with AIR Recon DL. So let's get into this now and start talking about improved resolution. And that's, of course, as I had mentioned, this is one of the quantities that AIR Recon DL delivers in the algorithm directly. You've seen images that perhaps look something like this, how AIR Recon DL can deliver sharper images. Conventional image is usually the one outlined in red, and the AIR Recon DL outlined in blue. What we see immediately from this example is these structures, this pituitary, even though they appear at different noise levels, I think one of the more driving elements of this image is that the AIR Recon DL image just appears sharper. The structures are more pronounced, the edges are more pronounced. And so let's talk about how that happens. Often when we do MR, we like to quantify things using phantoms. There are our true truth. They're structures, they have edges, they have very easily measured structures that we can quantify. So on the left being your conventional image of this phantom with varying diameter, structures, and on the right, the AIR Recon DL image of the same raw data. And you can see immediately that the image on the right has just much more well-defined structures at all of the levels of the radius, as well as considerably reduced noise. So you see a lot of the ringing artifacts, this Gibbs ringing artifact, and these kind of halo-like structures. They're simply not present in AIR Recon DL, and that's one of the reasons why we see the right image having a lot more resolution. So here's an experiment that we ran on a similar type of phantom, where we imaged the same structure. These are just basically line pair phantoms of a fixed diameter. So they're the same structure in all of the image I'll show you, but we acquired them with varying in-plane resolutions, and that range from 0.2 by 0.2 millimeters all the way up to about 0.78 by 0.78 millimeters. And so with conventional reconstruction, you can see that maybe the leftmost images, well, it seems to capture the edge information the best, and that's as expected. It's the highest resolution image. And as we move towards the right, we are less able to resolve the phantom structures to the point where it's almost, you almost can't quite dissociate one from the other, or at least it's at the edge of the perception. So those are the conventional reconstructed images. If I were to use AIR Recon DL and reconstruct the exact same raw data, and that's shown on the bottom row of the 5 images, this is what we see. Now we see that if I start with a 0.78 by 0.78, I hope you can tell that these structures are just clearly much more defined. There's more resolution in the images, despite the voxel size being perfectly the same between the top and the bottom. And in fact, we could go one step further and visually line up these images a little bit better. So now I see that this 0.26 by 0.26 millimeter in-plane AIR Recon DL image, that seems to line up a lot better with the conventional 0.2 by 0.2 image. Similarly, the 0.52 by 0.52 millimeter in-plane resolution AIR Recon DL image lines up with this 0.39 by 0.39 millimeter conventional image. So you get the idea. We're able to visually match the structures despite them having been acquired with different voxel sizes. So this is going to be an important feature that you need to be aware of when you use AIR Recon DL, and that is you can get by using larger voxel volumes for equivalent spatial resolution information. So let's kind of quantify this a little bit. If I were to make a chart here where the ordinate, the x-axis, is the conventional reconstruction in-plane voxel dimension, and the y-axis is the AIR Recon DL in-plane voxel dimension, I might see, if I were to go back to that example of those 5 phantom images, those 5 phantoms acquired with different in-plane resolutions, they basically can deliver this type of an equivalent resolution lookup table. Think of it as a lookup table where my 0.8, for instance, my 0.8 or 0.78 millimeter in-plane resolution with AIR Recon DL actually best lines up with something that's closer to 0.6 or perhaps 0.55 millimeters with a conventional reconstruction. And if you can follow this reasoning here, and from our calculated data, we find that that slope is about 1.4 with this experiment we ran. It basically is implying that with AIR Recon DL, your in-plane voxel dimension can be approximately 1.4 times larger than your conventional reconstruction. And so that simply means that you are getting higher resolution images despite keeping your voxel volume preserved or fixed. And we did this experiment in another way, another independent way, and we looked at simply the edge information of a phantom. So whereas I was looking at the ability to resolve structures, now if I were to look at the actual edge of a sharp structure, a phantom, and if I were, say, to plot the signal profile along these different edges, I might get some data that looks like this. You know, this vertical drop represents one edge and this represents another edge. And what I've got plotted here is original, think of that as the conventional image, and then 3 different levels of AIR Recon DL, typically that relate to the low, medium, and the high setting. And if I were then to take a derivative or really think of it as the gradient of that line profile, I would get these sharp spikes at these drops in signal and the upswing in signal. They basically represent the ability to resolve the edge structures. And this pink line, basically, the fact that it's the highest basically indicates that AIR Recon DL is doing a lot better than the conventional image at resolving the edge of that phantom. And a nice thing, and it's worth telling you and making sure you understand, that resolving capability is independent of the SNR performance. So whether we use a low, medium, or high setting with AIR Recon DL, you get the same edge sharpening improvement with AIR Recon DL. With this type of an experiment looking at the edges of the phantom, we came up to about a factor of 1.6. So if you remember, I previously showed you a factor of 1.4. This experiment gave a 1.6, so it at least tells us we're in the right ballpark with that kind of an improvement. So maybe the right answer is closer to 50% improvement in the resolution of the image with AIR Recon DL. But anyway, this gives you 2 independent means that we've confirmed the resolution improvement with AIR Recon DL. And independent, I should again add, of the SNR improvement factor. Whether you use a low, medium, or high, you get the same improvement in sharpness. And that's to be expected. So let's now talk about increasing the SNR of images. So we've all seen these type of images, perhaps in some of the displays that you've seen of AIR Recon DL. We've seen examples of a noisy image on the left and an AIR Recon DL on the right that appears to be noise-free. And you know, this is something we need to talk about. Again, same scan time, same voxel size, same raw data, just reconstructed with AIR Recon DL. We know with MR that the most straightforward way of improving the signal to noise ratio of images is to average. Unfortunately, you get just simply a diminishing return on your SNR, so that as you increase your number of averages, you get simply less and less additional SNR. That curve simply plateaus over time to the point where maybe there's not a lot of difference between going from a 10x to a 20x when you have a large number of averages. And so it goes as a square root behavior. Doubling your number of averages only results into a square root of 2 of your SNR. You get the idea. You've done MR and you know this rule pretty well. So if we were to look at this complicated chart, but let's just focus, I'd like you to focus on the black line and on the purple line. Don't worry about anything else, just focus on the black line. This is the SNR measured in a phantom as a function of the number of averages. So if we look at the black line, we can see this is a conventional reconstructed image set. Here's at 1 average, 2 average, 3 average, and the SNR slowly increases up to a point where at 15, you have an SNR of just a little bit under 30. With AIR Recon DL applied to the same images with the high setting, that's the purple line, we see that with a 1 average, we get nearly the same signal to noise ratio with AIR Recon DL as we did with the conventional image. So that tells us a good ballpark is that the signal to noise ratio of AIR Recon DL in that high setting with 1 nex is equivalent to the conventional reconstruction with 15 nex. Often we have a difficult time quantifying SNR in clinical images, and so sometimes we will use the number of average equivalents. So what you're seeing here is that there's approximately a factor of 15 to 1 in the SNR performance with respect to averages between AIR Recon DL and the conventional reconstructed image. So that's a very important thing, and we'll keep note of it. And if you want to read more about this experiment, you can be sure to go and see this reviewed article authored by, in fact, Mark Labelle, who was one of our inventors of AIR Recon DL at GE. Let's talk about now how the signal to noise ratio changes with voxel volume. So now that we have a good sense that the AIR Recon DL signal to noise ratio is considerably larger than conventional reconstruction, let's now look at how SNR compares with other parameters that we may change in the pulse sequence. Well, voxel volume is certainly one of them. This is the in-plane resolution as well as the slice thickness. So it's really a product of those 3 quantities. Let's suppose conventional reconstruction is in red and AIR Recon DL is a multiplication of that. So let's say that's the curve in blue. All of the sites will have a clinical signal to noise ratio threshold. Something below it, they won't accept, but as long as the SNR is above it, then the site is happy. But of course, all of the sites also have a voxel volume acceptable threshold, some clinical acceptable threshold. Anything higher than that voxel volume is unacceptable, and anything lower is acceptable. So for conventional reconstruction, that might be represented by this vertical line. But don't forget, with AIR Recon DL, that vertical line is shifted. I told you just before, a few minutes ago, that I can get higher spatial resolution with AIR Recon DL. And so I'm going to allow myself to shift that vertical line over with AIR Recon DL. In other words, I can get by with a larger voxel volume compared to the clinical reconstruction can. So now consider point A. Here's an image constructed with conventional reconstruction. It has, well, right away we see it has enough SNR, but it has been acquired with too large of a voxel volume. So it's really not clinically useful. AIR Recon DL can take that same type of an image and deliver a smaller voxel volume with the same SNR. So I have to acquire a new image with AIR Recon DL with a much smaller voxel volume to get the same signal to noise ratio as pointed out in point B. Conversely, if I had an image at point C with conventional reconstruction that did have a small enough voxel volume, but of course it had too low of an SNR, AIR Recon DL applied to that same data set could drive up the SNR and bring me to point B. So I hope you get the idea that AIR Recon DL can be used to increase the SNR as well as to reduce your voxel volume. Again, if you wanted to go to much smaller voxel volume, it can allow you to do that without paying the SNR penalty. And when we look at a chart like this and we really think about, well, what is the convention, what are the ranges that I can live with by simultaneously following my clinical SNR threshold as well as following my clinical acceptable resolution threshold, and we see there's not really a lot of space we have to work with conventional reconstruction, a very narrow range. But with AIR Recon DL, we have a very wide range. I can go from here all the way to over here, and I have a much larger voxel volume dimension to work with so that I have enough SNR as well as meet the requirements on resolution. And so I've got some images on the right-hand side, which basically speak to the same thing. They really represent points A, B, and C. Here we see point A. It is too large of a voxel volume. It does have adequate SNR. Point C has a very small voxel volume, but simply doesn't have enough SNR. And then point B gives you the best of both things, a small voxel volume and more than enough SNR to make your diagnosis. So that is how SNR and voxel volume behave with AIR Recon DL. And basically that's the point there. Let's take a quick look. I won't belabor the whole message here, but now if we looked at SNR as a function of scan time, so you recall this familiar square root curve for conventional reconstruction, and of course AIR Recon DL is simply something like a multiplication of the conventional reconstruction. And if we were to, again, give our clinical SNR threshold, our clinically acceptable scan time threshold, because maybe that's 3 minutes, maybe that's 5 minutes, but there is a number that clinics will want to have scans under. We have point A, we have point B, which gives you a much shorter scan time with the same SNR. Point C, it has too low of an SNR, but a good short scan time. And again, AIR Recon DL can deliver the point B with higher SNR, keeping the scan time fixed. And again, realizing the different ranges that you have to work with, very narrow for conventional, but much wider with AIR Recon DL. These are the scan time ranges that you can work with, simultaneously keeping the SNR high and your scan time low. And again, some more representative images that correspond to points A, B, and C. In particular, point B is that short scan time and also high SNR image to see what you want to see in the meniscal tear here. Okay, so with that said, I'll quickly go through this concept of protocol space. And we talked about SNR, how it compares with scan time and with voxel volume independently. Well, now we're going to put them both together in one chart. And if I were to, for conventional reconstruction, with an SNR of some fixed quantity, like as shown in red here, let's regard this as our clinical SNR threshold, such that any protocol that is to the left-hand side results in unacceptable SNR. So think of it as any protocol with too short of a voxel volume or too short of a scan time is going to deliver unacceptable SNR, but anything on the upper side of the curve gives you acceptable SNR. We, again, place our threshold levels for scan time, for resolution, and we see that with conventional reconstruction, we have a very small, clinically usable protocol space. If I set my scan time or my voxel volume in certain combinations, I can only do so in this small red triangular region. With AIR Recon DL, that region is considerably larger. My SNR curve is much lower because I get more SNR, so I'm allowed to go to a curve that goes closer to the origin. My clinical resolution threshold has pushed to the right-hand side, and my clinical scan time threshold remains the same, but you get the idea. Now I can, I'm free to scan for resolution, for speed, for SNR, or for some combination of all three together, simply that I couldn't do with conventional reconstruction. I have a much more freedom with AIR Recon DL. And if you want to read more about this, you can take a quick screenshot of this barcode, of this QR code, and read in more detail this concept of protocol space. But it really is a good way of thinking of what AIR Recon DL does to your protocol parameter space. It basically expands it to a point where you can do more things with it. Okay, so that said, let's talk about consistency and scan times. And You know, when we got AIR Recon DL and we're doing a lot of volunteer scans, we wanted to measure, well, just how can I break it? What can I do with the parameters and with the protocols? And so this is an experiment we did in a shoulder, obviously, where we have a conventional standard prescription, and we simply changed 4 independent things. We did some rescans of the shoulder, going to higher bandwidth, reducing the number of averages, going to shorter, thinner slices, going to higher echo train lengths. All of these 4 things had varying results. They did something bad to the image. Some were worse, some not so bad, but the overall variation was considerable. From this conventional image on the left-hand side, I got quite a range of results that some I expected, some I didn't. All of this is with conventional reconstruction. That same data reconstructed with AIR Recon DL shows a much tighter grouping of image quality. Now, all of these 4 images almost looked identical, and I can't really tell the difference which is which. And it basically tells me that AIR Recon DL can just be used. It provides you that consistency and considerably reduces the variation in the image quality that you will get in your as you set your protocols. So basically, this is a take home. It can lead to reduced image quality variation. You know, another thing that it can do is lead to more consistent scan times and shorter scan times. So here's an experiment that we collected some data from one of our trusted sites. These happen to have been 2D fast-spin echo pelvis scans. Maybe I had several hundreds of them, but if I were to basically create a histogram of all of the scan times of all of these hundreds of images with conventional reconstruction, I had a mean distribution of about 242 seconds. So that's, you know, that's going to be maybe 4 minutes of an average scan time with a standard deviation of about 100 seconds. That was before. Now with AIR Recon DL, the new practice, once this site implemented AIR Recon DL into their practice, again with pelvis scans, 2D fast-spin echo, that mean dropped considerably from 242 seconds down to 108 seconds, and the standard deviation considerably reduced from 100 seconds down to 44 seconds. So you get what I mean here. We now have a lot more consistent results, and the variation is less. The average scan time is less, and so this site is much more happy. Not only do they have shorter exam times, but they all have more predictable exam times. There's much less variation that they see. And that really applies to AIR Recon DL, the impressions of AIR Recon DL at a number of different sites, whether they're from university hospitals or outpatient imaging centers. If you pick any anatomy, a knee, a C-spine, IACs, breast, what have you, they have quantified the average reduction in percent. So here we see 32% across all anatomies, 29%, 47%. That's very typical. We see anywhere between 30 and 50% at most of our sites for exam time reductions. And of course, we know what sites are doing with that added time. Their patients are happier. It allows them to disinfect between the patients. And then of course, it allows them to scan more patients per day. I'll briefly close here with just a quick comment on what AIR Recon DL can do for diffusion imaging. So diffusion imaging was one of the most recent additions to the AIR Recon DL family. It, of course, comprises a standard routine brain exam. It can be used, obviously, in other anatomies like the prostate. But we did notice that AIR Recon DL is used a little bit differently with diffusion-weighted imaging than it does for, say, 2D fast-spin echo. And one of the ways is that we saw customers, they really weren't changing the resolution of the diffusion-weighted image, but they were changing the B value. They were going to higher B values. And so this balancing act shifted a little bit. Instead of resolution, we have b-value, but we still have SNR and time to balance all of those three things with. So if we think about how SNR changes with the diffusion b-value, you probably all know that it decreases. It decreases exponentially. Conventional reconstruction, AIR Recon DL, they both decrease exponentially. The higher the b-value, the less signal you have, simply put. And if we, again, create the same type of charts of a clinical SNR threshold, a clinical b-value threshold, we see the same kind of findings with AIR Recon DL, and simply that it can be used to increase SNR, and it can also be used to increase the b-value at no cost to the SNR. And so, not to belabor the point, if we look at some representative images for these points A, B, and C, here we have point A, which is a good SNR image, but just simply too low of a b-value. Point C is a high enough b-value of, say, 2,500, but it seems to lack a little bit of SNR. And then, of course, point B, I get the best of both worlds, and I have a high b-value and high SNR. So that's just one little difference between how AIR Recon DL works with diffusion-weighted imaging. It allows the higher b-values as it maintains sufficient SNR. And if you are concerned about how does that protocol space look with diffusion-weighted imaging, this is a little bit how it works, where we've plotted scan time, diffusion b-value, and the contour of the SNR, and you kind of get the same impression here with AIR Recon DL. You have a larger protocol space where you can get higher SNR or higher b-values or a faster scan, or really some combination of all three together, things that you simply couldn't do in this small red parameter space with conventional reconstruction. And so I think I'll close it there. I gave you a good quick look at how SNR varies with AIR Recon DL, how it had benefits for spatial resolution. I'll leave you with some things that we want to follow up, and maybe if you're interested in a study, maybe we should talk. But one thing that we know is true, but we have yet really to quantify, is how are the images easier to read? How can they be read quicker and result in less eye fatigue? And I think that there are great things that we can measure, but this happens to be one area that I think really represents the final end game productivity, and that is how the radiologists, with the thousands and thousands of images that they have to read every day, how do they feel at the end of the day after reading AIR Recon DL images? And so I thank you for your attention, and I think I'll close it here.
So, Robbie, again, thank you very much for your presentation. Great presentation. We have just one question here, and the question is: so you show a lot of numbers like 1.4 increase or 1.6 or a lot of increase. But is this the limit, or can we expect more out of the AIR Recon DL? What is the next AIR Recon DL?
Well, so that represents the in-plane dimensions with 2D scanning. I would say that would be an experiment worth repeating with a 3D AIR Recon DL acquisition, where typically we scan with isotropic resolution. So maybe that factor is going to be even larger with 3D imaging, where we now have 3 dimensions of isotropic resolution.
Okay.
It could be a lot higher.
Yeah, great news. Okay, Robin, well, again, thank you very much for your time, your presentation. See you next year for the next Signa Masters Latam, okay?
My pleasure, thank you.